Competency 5, Engage in Policy Practice. The policy that I chose was EMTALA, which stands for the Emergency Medicaid Treatment and Labor Act. The Emergency Medicaid Treatment and Labor Act is a federal law that requires anyone coming into an emergency department to be stabilized and treated, regardless of their insurance status or ability to pay. However, since its enactment in 1986, has remained an unfunded mandate. EMTALA requirements are that hospitals are responsible for treating medical emergencies, but not held to preventing those emergencies, and in most states not provided the funding to address those medical needs. Emergency departments are required to perform an examination on the individual and are expected to treat and stabilize them prior to transferring them if need be, or confirming their ability to pay. And efforts to promote equality with a lack of compensation can cause a shortage on resources and the serving capabilities within emergency departments and further community resources. Guidelines or failure to follow guidelines and address needs results in facilities being held liable. Therefore, no individual should be turned away on any basis of discrimination. Emergency medical conditions are defined as someone being severely ill with serious health outcomes as a result if not treated. This applies to those individuals who come in seeking medical treatment, and the emergency department is responsible for treating these patients, stabilizing them, and further following them through their recovery and discharging them from the hospital appropriately. Individuals must be treated, and if unable to be adequately treated, they are to be transferred. However, with transfers, there come certain requirements that they have to be stabilized, and if they cannot be stabilized or the hospital lacks the resources, there has to be appropriate forms and procedures to be followed, and departments have to then accept transfers if able to adequately address their needs. Some advocacy efforts needed are based on different perspectives, such as the hospitals taking the risk of accepting patients with no financial support. Oftentimes, patients in need of care are taken on as charity cases. However, this depends on the amount of resources needed. This also depends on the complexity of a patient. So if a patient is in need of resources that are inaccessible to certain communities, it often leaves a difficult path for facilitators such as social workers, caseworkers, medical professionals in general to kind of connect them to those resources that they need once discharged from the hospital. However, there are ethical considerations in addressing needs of patients and their recovery needs. It's important to take into account their psychosocial support, whether that be family, friends, or their ability to access certain resources within their communities, or if they have the ability to recover in the right or with the right, adequate, and efficient treatment. Some federally qualified healthcare centers and community clinics only address minor medical needs with the resources that they have, therefore are unable to screen and prevent such medical conditions that lead to emergency services. Another advocacy effort is to include end-stage renal disease as an emergency medical condition. Many individuals, specifically in the undocumented population, face end-stage renal disease and are in dire need of dialysis, standard dialysis. So instead of risking and waiting until they are between life and death, they have access to the adequate care that they need, based off of research and information. This kind of policy change would positively influence communities as well as the healthcare system and its community. And these are my sources.